You can start whenever, Ehsan. I think, yeah, Rohan's getting ready.
Okay, no problem. So, hello everyone. We shouldn't wait for any other fellows. Everyone is here. Let's take a look. Okay.
Yeah, Rasha might be on the inpatient service. She might come later.
Should we wait a couple of minutes or go ahead?
Sure. Okay.
Just maybe 1 minute.
Yeah, we just got one patient. She's communicating with the team.
Okay, just got the patient, so then probably we should start. Okay, so hello everyone. Today we're going to talk about renal cystic diseases. Polycystic kidney disease can be acquired in adult life. So many patients may develop kidney cysts by the process of aging. You have seen patients on dialysis, those patients with end-stage kidney disease on dialysis, they can develop kidney cysts. Some medications, some hormones can cause polycystic kidney, but most cases of the patient with polycystic kidney disease are actually hereditary. Most common form is ADPKD, autosomal dominant polycystic kidney disease, type 1, which is due to mutation in PKD1. You have ADPKD type 2, which is related to mutation in PKD2. There is autosomal recessive polycystic kidney disease, which occurs usually in early life due to mutation in PKHD1 and other mutations. There is another group of renal cystic diseases called nephronophthisis. They have a hereditary pattern of autosomal recessive due to mutation in NPHP, nephrocystin. I'll come back to this topic later in the talk. Another category is multi-medullary cystic kidney disease. The other name is autosomal dominant interstitial kidney disease. Due to mutation in UMA, TAM protein, these patients can have an adult onset CKD, hyperuricemia, gout. There are other genes which can be involved in this category of polycystic kidney diseases, which are not listed here, such as REN, REN, mucin 1. So these are rare diseases, but you will see these patients mainly on your board exam. So you need to be familiar with these diseases. The other category is mutations in MKS, which can cause Michael-Gruber syndrome, another polycystic kidney disease. Bardet-Biedl syndrome. Usually these patients, they have a syndromic manifestations such as eye involvement, retinitis pigmentosa, polydactyly. They have a mental retardation, hypogenitalism. Also, the other genes like can be mutated and resulting in polycystic kidney disease, such as TSC1, like tuberous sclerosis. These patients present with some skin manifestation. They may have ophthalmology manifestation. They may have tuberoma in the brain causing seizures. VHL, Wilms tumor, the MET gene, they can cause, these are other categories of the diseases which can present as polycystic kidney. Some of the pictures of these diseases like ADPKD, ARPKD, patient with nephronophthisis, patient with renal cancer, von Hippel-Lindau. So the bottom line message is that not everyone with polycystic kidney disease is ADPKD, but by far the most common cause of autosomal dominant polycystic kidney disease is the most common form of polycystic kidney disease. It occurs in 1 in 800 live births. It affects 500,000 persons in the US and up to 6 million globally. And up to 7 to 10% of the patients with end-stage kidney disease on dialysis, ADPKD accounts for them. There are two types of ADPKD. Type 1, which is caused by mutation in PKD1, it accounts for the majority of the cases. And also there is type 2, which is the mutation is PKD2. Up to 15% of the cases are type 2 ADPKD. As far as the protein products of these genes, the PKD1 encodes for polycystin 1, and then PKD2 encodes for polycystin 2. Polycystin 1 is a membrane receptor protein which can bind, interact with many other proteins, carbohydrates, lipids. It can stimulate the intracellular responses. Polycystin 2 is a calcium permeable channel. There are overlapping features, the ADPKD type 1 and type 2. They do have similar pathologic and physiologic features, but you need to know that the type 2 disease has a later onset of the symptoms, and they tend to have a longer life expectancy. As far as how these patients develop cysts, you can see the normal nephron on the upper panel. This is a patient with autosomal dominant polycystic kidney disease. This is a pattern seen in ADPKD, and as you notice, these outpushings are basically arise at every segment of tubules, and they can rapidly close off from the nephron of origin. But in contrast, the patient with ARPKD, the cysts are from collecting tubules, and they tend to stay connected with the nephron of origin. Regarding the underlying mechanisms, there is a role for EGFR ERB complex. Has been shown that the abnormal polarization of the epidermal growth factor receptor can play a role in development of these cysts. You can look at this part of the image. These are the PC1 is a polycystin 1, polycystin 2. These proteins are located in the primary cilia. Their exact function is not clear, but it's known that lack of polycystin 1, polycystin 2 can basically increase the intracellular calcium, which suppress the NAC6, and this will eventually lead to increase in cyclic AMP and eventually fluid secretion through CFTR. I'd like to get your attention to the V2 receptor role here. Vasopressin can activate this cascade and can increase the cyclic AMP, which eventually will increase the fluid secretion. And I will get back to this point for the V2 receptor because it has been a target for therapeutic approaches. So how do we diagnose patients with ADPKD? In those patients who have a clear family history of ADPKD, having a renal ultrasound is usually sufficient to make the diagnosis or even to exclude the diagnosis. In some cases, when the diagnosis is not clear, you have some atypical features, there is a concern for a complex cyst, there's a concern for a kidney mass, you can consider doing MRI. As far as genetics testing, some experts would suggest to do the genetic testing to confirm the diagnosis if available, especially in those patients who may be a consideration for transplant or for prenatal planning purposes. But whenever you are ordering a genetic test for this patient, you need to counsel them as far as the potential implication, as far as the burden that may have for them, as far as the psychosocial, it may have some implication as far as their job. So always counsel them before ordering a genetic test. How we use the ultrasound to make or exclude the diagnosis for patients with ADPKD. The criteria is mainly dependent on the age of the patient. So a younger patient with the family history of ADPKD, if they have 3 or more cysts, you can confirm the diagnosis. As people age, there is a chance for developing the cyst, acquired cyst, as I explained earlier in the talk. So someone who has an older age, you will need more cysts. For example, at the age of 40 to 60, you would need more than 2 cysts in each kidney to have a high certainty to confirm the diagnosis. As far as exclusion of ADPKD in someone with family history of ADPKD, again, if someone is in the younger age, you need to be careful. Absence of, they may develop cysts later in the life. So, but if someone an older age having no cyst has a high degree of certainty, you can exclude the disease. How about those patients without family history of ADPKD? You know, in your practice, you may end up seeing patient adults so that they have polycystic kidney, and not everyone, as I mentioned earlier, not everyone with the polycystic kidney is ADPKD, especially if you do not have family history. It can be challenging, and there is no well-established criteria to confirm the diagnosis in these patients. Some experts suggest that having more than 10 cysts of more than 5 millimeters in each kidney, you can consider the diagnosis of ADPKD, especially if the kidneys are enlarged, and or in the case of having liver cysts, and in the absence of the features for the other possible polycystic kidney diseases. I showed you a slide that many patients may have like a syndromic feature. You have to look for it to make sure you are not missing other possible genetic diseases. And genetic testing should be considered for these type of patients, especially if you are considering, as I said, for transplant, prenatal planning, you need to consider the genetic testing for these patients. After you establish the diagnosis of ADPKD, you need to make sure that you have a risk assessment as far as identification of those patients who are at high risk, because it is very important to know what type of patient with ADPKD is at risk for a rapidly progressive disease. One of the measures that you can use is total kidney volume. And there's a link here. I put it in the slide so you can use it later. This is from the Mayo classification. You can use the calculator to help you calculate the total kidney volume. In our radiology at GW, you can, when you order your lab, for example, MRI, you can ask to measure the total kidney volume. And why we're using this total kidney volume in patients with ADPKD? Many of these patients, their kidney size can continue to grow. They can become very enlarged while their GFR can remain preserved. The creatinine is 0.8, but the kidney is very large, like 17 centimeters, for example. And the total kidney volume can better predict their risk. There are other approaches to identify those patients who are at risk for rapid progressive disease. There is a classification that you can, the scoring system you can use is a PRO-PKD. In those patients, mainly the genetic data is available, and not many patients have a genetic data available, but because of the decreasing cost of the genetic testing in the future, you may see more and more genetic data available. So it's good to be familiar with the scoring system that use those genetic criteria. The scoring system is from 0 to 9. And the parameters include sex, presence of the hypertension before age of 35, appearance of the first urologic event before age of 35, having the mutation PKD1 versus PKD2, or having the truncating versus non-truncating PKD1 mutation are incorporated in the scoring system. If someone has a score of 0 to 3, is considered as a low risk. 4 to 6 is considered intermediate risk, and the high risk patient has a score of 7 to 9, which are at increased risk of progression to end-stage kidney disease. So what can we do for these patients? Once you make your diagnosis of ADPKD and you have identified those patients who are at increased risk, and what can you do? Regardless of the increased risk, everyone needs to get the blood pressure under control. Even every patient, regardless of those are at increased risk or at the increased risk for the rapidly progressive disease or not. So management of the blood pressure in these patients is very important. The goal of the blood pressure based on the HALT PKD trial is 110 less than 75. In those young individuals who do not have significant cardiovascular burden. As far as their diet, we counsel them to have a low sodium diet, 2 grams per day, and you have to advise them to for hydration to drink more than 3 liters of fluid per day, unless their GFR is less than 30, which can be challenged to have them drink a lot of water. Earlier in the talk, I mentioned that there is a role for V2 receptor in the pathophysiology of developing polycystic kidney disease. V2 receptor stimulation could induce the cyclic AMP, which will eventually increase the fluid secretion and cyst formation. And that's why medication TOLVAPTAN, which is a V2 receptor antagonist, has been used in patients in ADPKD, in those patients with the estimated GFR more than 25, and those which were at risk for rapid progression disease. So they use what patient is at the risk for rapid progression. Those patients, I showed you the Mayo classification at the 1C, 1D, and 1E. These patients are at increased risk for rapid progression of the disease, and that's why it was important to have an understanding of their total kidney volume, because there is a role for medications, therapeutic approaches for these patients. So in the trial, they used those patients, they enrolled the patient with age less than 55, an estimated GFR less than 65, the kidney length more than 16.5 centimeter, those with the pro-PKD score of more than 6. In TEMPO trial, they enrolled more than 1,000 patients. The GFR creatinine clearance more than 60, and the total kidney volume of 750 ml. And what they noticed that the annual increase in total kidney volume was smaller in patients who were on TOLVAPTAN. The annual decline of estimated GFR was also slower among patients with TOLVAPTAN compared to placebo. Also, TOLVAPTAN reduced the rate of decline in kidney function at 3 years, and also decreased the rate of clinically significant kidney pain in these patients. The kidney pain can be very serious for these ADPKD patients. Also, they noticed that TOLVAPTAN led to some improvement in both systolic and diastolic blood pressure in the trial. On the left panel, you can see the blue line is TOLVAPTAN, and the placebo and the dotted red. You can see the change in total kidney volume was lower in patients with TOLVAPTAN. On the subgroup analysis of these patients, all the subgroups, the age less than 35, more than 35, hypertension status, those with GFR less than 80 or more than 80, and the total kidney volume less than 1,500 or more than 1,500 ml, all favored TOLVAPTAN. In TEMPO trial, they mainly enrolled those patients with relatively high level of GFR. And this was followed by a REPRISE trial, which in REPRISE, they enrolled patients with more advanced stage of kidney disease. The GFR was as low as 25 in these patients. And again, REPRISE showed benefit with tolvaptan. And also I have to mention that in Reprise, what they did, they had a pre-randomization period to make sure they can tolerate tolvaptan. Not everyone can tolerate tolvaptan. I'll talk about its side effect profile, but they did not randomize those who could not tolerate tolvaptan. So eventually in the trial, it showed that the change from baseline estimated GFR was lower among those assigned to tolvaptan compared to placebo. The blue line shows the tolvaptan, placebo in the red, and this is the main change of from baseline over 12-month period. As far as the contraindication for tolvaptan, tolvaptan cannot be used in patients with a liver impairment or liver injury, with the exception of those patients with uncomplicated polycystic liver disease. For the side effect profile, you may have up to like 50% of the patients report thirst, polyuria, nocturia. They may have polydipsia, hypernatremia in a small number of the patients, and increased liver enzyme, which is the serious issue that which every time that you start someone on tolvaptan, you need to counsel them for these side effects, especially you need to discuss about the potential liver toxicity. And actually there is a monitoring program for every patient who is started on GnRQ. GnRQ is another name for tolvaptan. It's a REMS program that if you decide to start someone on tolvaptan on GnRQ, then you need to register in REMS program. And also you have to go through the side effect profile with the patient, needs the consent, which needs to be documented in the chart, and very rigorous monitoring. So after you start the tolvaptan, you have to monitor the ALT, AST, bilirubin, the whole liver function at 2 weeks, 4 weeks, and then monthly for 18 months. And the medication, it should be mailed to the patient through the specialty pharmacy. It's not that every pharmacy can provide that medication. During the monitoring process, if you notice that the patient, the ALT, AST are up to more than 2 upper limit of normal, tolvaptan should be stopped. And you need to repeat the test. If it keeps rising, then you need to stop the tolvaptan and refer for further evaluation. But if ALT, AST stabilizes or even resolves, then tolvaptan can be reinitiated. As far as the kidney transplant for patients with ADPKD, the rate of complications for transplant are similar to other populations. In preparation of the kidney transplant, it is suggested that you can screen them for intracranial aneurysm. As far as the question about nephrectomy, most patients they do not need nephrectomy, but if for some reason they need to basically remove to have a space to accommodate the allograft, it can be done. And as far as the results of the outcome of these surgeries, if you do the nephrectomy before, during, or after kidney transplant, the outcome were pretty much similar. But not surprisingly, if you do it at the same time, it appears to be associated with the better patient satisfaction. Patients on ADPKD and dialysis, actually they do pretty well. The survival of these patients is somehow better compared to the other patients with end-stage kidney disease. And it's mainly related to the fact that the patient with ADPKD tend to be like healthier. They do have lower cardiovascular burden. So that's most likely the reason that the survival appears to be better. But some clinical problems can happen in this patient on dialysis. your ADPKD dialysis patient, sometimes they have kidney pain, gross hematuria, infection that you need to be aware of. Peritoneal dialysis can be done in patients with ADPKD, and actually there are some data showing that the patient with ADPKD and peritoneal dialysis can do better compared to hemodialysis. And again, there are limited evidence, and there are significant selection bias with regard to this type of assessment. But it can be done in patients with ADPKD, but there is an increased risk for peritonitis due to cyst infection or complication of diverticular disease in these patients. So any questions before we move to the next category of the polycystic kidney diseases? Any questions? As far as the diagnosis of ADPKD, identifying those at high risk for rapidly progressive disease.
Ehsan, I have a question. In terms of genetic testing, there's a lot of, there's almost like registries being maintained of newer mutations. And as they, discover these new mutations and we have the existing genetic panels, a lot of the times in younger patients, if the genetic test is quote unquote negative, and there's a suspicion for PKD, how do you handle counseling and how do you prognosticate those patients or even diagnose them?
Thanks for the great question. So if we have a high suspicion and the PKD1 and PKD2 are negative, it can be considered to do the whole exome and to identify those possible genes.
But we don't have that commercially available, right? I mean, we'd have to send them to like a special, like a PKD research lab.
At GW, but there are basically a growing number of the labs which are providing these tests.
Okay. Okay.
And now I think Dr. Shankar, in collaboration with Terra, they do offer advanced genetic testing. So the fellows, any questions?
Sorry if I missed that, if you commented on that and I missed that, but how often should we be doing the MRI to measure the kidney volume?
So you do not need to do the repeated MRI on these patients. So if you have a patient with your diagnosis is not clear, then you can do MRI if there's a concern for a complex cyst or like a renal mass. You can do your MRI. But in the case of that you decide that you want to consider the patient for GnRQ, TOLVAPTAN, you can use ultrasound or MRI to have a measurement of total kidney volume. I tend to order MRI at GW. We have a great radiology group that they provide a good measurement. And if I want to start someone on TOLVAPTAN, I do consider doing the MRI, unless the diagnosis is very clear. If you have someone with clear diagnosis, family history, and you have an ultrasound with the very enlarged kidneys, like more than like 16.5 centimeter, then you have your diagnosis and it's clear, and you do not need even to order your MRI.
See, thanks.
Sure. Any other questions? As far as ordering the GnRQ and REMS program registration, if you have questions, you can always contact me. So let's move to the next category of polycystic kidney diseases. Nephronophthisis is a group of autosomal recessive cystic kidney diseases, which most of the time typically progress to end-stage kidney disease, unfortunately. And these diseases can be due to mutation in a large number of genes. I think I showed you the NPHP 1 to 9, the nephrocyst. All of these genes can lead to the nephronophthisis. And the main problem is they encode proteins which are involved in the primary cilia function, which lead to cyst formation. And they do have extrarenal manifestations, such as retinal degeneration, cerebral ataxia, liver fibrosis. So when you evaluate someone, usually young individual with these conditions, think about the nephronophthisis. Their clinical manifestation usually include polyuria, polydipsia, because they do have significant tubulointerstitial disease, impaired urinary concentration. And when you do your urine sediment, usually it's bland. They may have mild degree of proteinuria, tubular range proteinuria. But if you catch them later in the disease, which happens quite often, then they may have a glomerular range proteinuria, and usually is because of some sort of like a secondary, like adaptive FSGS. There are three clinical variants for nephronophthisis. There is an infantile form, juvenile, adolescent form, and they have different type of mutations that usually, if there is a concern, then the panel of these genes should be ordered if the diagnosis is desired. As far as the extrarenal manifestations, it can happen in up to 20% of these cases. There was a study, they included more than 1,000 families with NPH. Interestingly, most of the patients did not have the mutation, but among those identified genes, NPHP1 was the most frequent. And you need to know that the NPH is a major clinical finding in the number of the syndrome. If you hear some name of the syndrome which you are not sure, and think about NPH. Again, these are rare diseases, but it may show up on your board exam. NPH almost always progress to end-stage kidney disease at a young age. And the other clinical feature is the most patients can remain normotensive somehow because of that tubulointerstitial disease, probably the renal salt wasting, they use a volume and the blood pressure may remain normal. Maybe that is the underlying cause of being normotensive. When you do the ultrasound on these individuals, you do not see those like large polycystic kidney disease that you see in ADPKD. When most of the time when we see these patients, they have an echogenic kidney. They may have some cysts at the corticomedullary section, and the biopsy they do have significant tubulointerstitial disease and the tubular cysts. With regard to the treatment, there is no effective way that you can prevent or treat these disorders. Mainly the supportive care. If they get to advanced stages, dialysis and kidney transplant are the options at this point. But hopefully, we will, as we will learn more and more about the underlying condition, these genetics, we may have some therapeutic approaches in the future. Let's talk about a little simple cyst. If you have come to the ultrasound clinic, you know that the kidney cyst is the most common form of abnormality that we see in our patients. Usually by process of aging, patient may develop a simple cyst. Smaller cysts, less than 1 centimeter, can also occur in other conditions, which may not be not every small cyst is a simple cyst. So it may occur in other conditions such as medullary sponge kidney, autosomal recessive PKD, autosomal dominant interstitial kidney disease. They may have small cysts. There's a classification to basically risk stratify the kidney cyst. Is a Bosniak classification. I'd like to draw your attention to the category of 2F. That F means the follow-up. These are the patients that when you see that type of cyst, then you need to think about the follow-up, repeat imaging. The 2F category is those patients with the relatively larger cyst, more than 3 centimeters. If you see septation, or some internal label like a nodular calcification, these patients need to have a follow-up imaging. Class 3, class 4, these are the lesions with enhancing lesion, which are very highly likely to be malignant. And the approach for those category of 3 and 4 is mainly surgical and removal of the mass. For the category 1 and 2, you do not need the follow-up. It's always good to have the to compare to the prior imaging. But if there is any doubt, if there is any suspicion that the cyst may not look simple, you would need to have a follow-up imaging for these patients. For category 2F, as I mentioned, always try to obtain the prior renal imaging for comparison. If not available, then we would consider doing further imaging. And as a general rule, among radiologists, if there is a suspicion, then they, for example, if they think it's like is it 2 or 2F, they try to consider the higher category and do the appropriate workup according to that. So when as a algorithmic approach to the patient with the bilateral kidney cyst, always ask for a family history of polycystic kidney disease if in those patients who do not have a family history or is atypical, very early onset for ADPKD, consider doing the genetic study. Most of the patients, they do endorse a family history of polycystic kidney disease. In these patients, usually we start with imaging, like a kidney ultrasound. And if the genotype is known, if the patient has a PKD, the family, they have a PKD1 mutation, at the age of 15 to 29, having more than 2 cysts can confirm the diagnosis of ADPKD. In the age of 30 to 59, having more 2 cysts in each kidney needs to confirm the diagnosis. And those with the age of more than 60, they would need to have more than 4 cysts in each kidney to confirm the diagnosis. For those patients with the genotype of PKD2 mutation, or if you do not know the family genotype, if the patient is among between 15 to 39, you would need more than 3 cysts, unilateral or bilateral, to make the diagnosis. Age of 40 to 59, you would need 2 cysts in each kidney. And those more than the age of 60, you would need 4 cysts in each kidney. And if there is any atypical feature, if you notice any extra-renal manifestation, and that's why it's very important to dig into it, to keep asking about the other possible extra-renal manifestation of a patient with polycystic kidney, and consider genetic analysis. And as Dr. Rangaswamy addressed, that if in some cases you may do the genetic analysis and they do not have the PKD1 and PKD2. In those cases, you have to basically broaden your differential diagnosis and maybe further additional genetic studies. As I mentioned, sometimes the whole exome can be considered. But again, these studies are not widely available. What you need to do is just to make sure you have a broad differential diagnosis, and keep in mind, not everyone with bilateral kidney cyst is ADPKD, and or they may have genetic disease due to other mutation. So you need to check for the other mutation if it's not positive. And sometimes the non-genetic causes can cause bilateral kidney cysts that you need to be aware of, lithium-induced nephropathy or acquired renal cystic diseases. So let's do a few cases now. So we have a 34-year-old woman who is referred to a clinic for evaluation and management of the macroscopic hematuria and occasional flank pain. She does not have hypertension, headaches, urinary tract infection, or kidney stones. Patient mother and maternal aunt have ADPKD and are currently receiving hemodialysis. On physical examination, her blood pressure is normal and her kidneys are not palpable. Lab shows hemoglobin 14, serum electrolyte within normal limits, or creatinine of 0.9. UA shows hematuria, and on the urine microscopy, you can see 100 monomorphic RBCs. So which one of the following is the next most appropriate diagnostic study? A, renal ultrasonography, B, CT scan, MRI, or genetic testing for PKD1 and PKD2? You can unmute yourself and let us know your choice.
I guess I would go with A.
A, okay. How about MRI? Anyone wants to do MRI? Or
I think
genetic study?
is probably the best place to start.
I'm sorry, what?
Ultrasonography is probably the best place to start.
Absolutely, absolutely. I totally agree. And as we discussed, most of these patients, if with the family history, just an ultrasonography is sufficient to make the diagnosis. But you can consider CT, MRI, genetic testing if there is a suspicion. Or if you see complex cyst or mass, then you have to do more imaging. Our next case is a 25-year-old male is referred for evaluation of asymmetric kidney size and elevated serum creatinine. He has developmental delay, retinitis pigmentosa, hypogonadism, and obesity. He has no family history of kidney disease. On physical exam, the body mass index is 32. There is a gynecomastia. His phallus is small, and testicular volume is 8 bilateral. There is paucity of axillary and genital hair. His cognitive function is impaired. Lab shows a serum creatinine of 1.5. UA is unremarkable. Kidney ultrasound shows 11 centimeter left kidney, right kidney 9.2. There are 4 cortical cysts. The largest is 0.8 centimeter. Nuclear study shows 25% of the total kidney function is derived from the right kidney. So which of the following is the most likely diagnosis? ADPKD, ADPKD, multicystic dysplastic kidney, Bardet-Biedl syndrome, or Senior-Loken syndrome?
Is it?
And you can use this slide. It's an open book question on board exam.
Is it D? Oh, which one was that thing? So can we see the answers?
So is it ADIKD? ADIKD, the older name is medullary cystic kidney disease. So in this patient, there is no mention of gout or hyperuricemia, so which makes the UMOD less likely, right?
Yeah, so I think it's D, right?
So what is D? Bardet-Biedl syndrome. Anyone wants to disagree?
I agree.
Okay, I agree as well. Again, these are rare diseases, but you may see these patients on your board exam, so you need to be familiar with this condition. Our next case is a 46-year-old woman with ADPKD and hypertension. She is concerned about her risk for CKD progression to ESRD. Her father began dialysis when he was 47 years old. She recently did a screening and was found to have a total renal volume of 800 cc. Lab study shows a serum creatinine of 0.8, uric acid level 3, cholesterol 164, PG 60, HDL 62, LDL 90. The 24-hour urine shows a creatinine clearance of 106 and the sodium excretion of 106. So which of the following is the best predictor for risk for progression of CKD? A, serum uric acid level, urine sodium, total renal volume, HDL, or female sex?
This is a guess. It's either B or C. I would go with C. I don't know.
Why?
Great. See.
Wait,
The other ones don't really make sense. I think so B would be, I think we discussed about the ADH, right? So the ADH, if the serum sodium is high, urine sodium excretion is high, that may be indicative of high ADH, but that increased total renal volume can also be an answer. So I'm not sure.
That's the question. So the ADH, can you repeat what you just said as far as the urine sodium and ADH? That's not the correct answer, but I just want to address that the issue of the sodium and ADH.
So I mean, I think, yeah, I mean, it's either B or C. I mean, I'm not sure which one it is.
So
But
let me, so as far as the ADH, so there is a non-osmotic release of ADH, but the ADH usually responds to the osm. So your urine sodium, the total urine sodium is not influenced by your ADH. Does that make sense?
yeah, that makes sense.
Okay, so for a patient with ADPKD, as I mentioned in one of the slides, I can go back and show it to you again. So the total renal volume has been shown to be a better marker for progression of the disease. So these patients can their kidney size can grow, can become very enlarged, can get to like 17 centimeters, 18 centimeters, but their GFR may continue to remain within normal limit, preserved. So, and that's why we use this total kidney volume to assess the as a marker for the progression of the disease. And the calculator, so since you brought and we do have some time, let's, we do have this calculator that you can use to measure the total kidney volume. And there is, let me click on that.
can I just ask a question about the prognostication? Is there any association with serum sodium at all?
No, so the serum sodium, you are talking about the patients on TOLVAPTAN, or overall you're talking about the patient with ADPKD?
The overall patients with this condition, is there any association with hyponatremia and prognosis or risk of progression, I guess?
Not as far as I know. I don't think in the tempo reprise they have looked at the serum sodium association.
So I think what's happening is you guys are maybe confusing the fact that there is, increased cyst growth with higher vasopressin activity with, any hyponatremia. These patients are not going to be hyponatremic. They also don't have excess ADH. It's even under the influence of existing ADH levels, they actually will have increased cyst growth. And that's why these measures like avoiding caffeine intake, increasing water intake so that you try to suppress ADH just dietarily, and vaptans are a pharmacologic way of suppressing it, have some data in terms of reducing cyst growth. But it doesn't mean that these people are going to be hyponatremic or salt losing. I mean, the salt losing could be in one of these genetic syndromes. But you shouldn't confuse it with, abnormal baseline levels of ADH. These people don't, they're just more sensitive to existing ADH levels in terms of cyst growth. Does that make sense?
And the salt wasting, is not the one of the featuring ADPKD. There are some other polycystic kidney diseases, like NEPHRONOPTHISIS. In those patients, you may have that salt wasting, but that's not a typical feature of the patient with ADPKD.
Exactly.
So just wanted to show you this ADPKD sim. It's a useful tool. Since we have a few minutes, I can show it to you and you can use it. So, there are different tools that you can use to identify those at risk for rapidly progressive disease. For example, if you order MRI and radiology give you a measurement of total kidney volume, you can use it in this calculator. I can just give you an example. You can use this like a simulator example, but if we can use our own example. So this, just assume you have the total kidney volume that you got it from your MRI, and then you just put it in the calculator. If the total kidney volume, for example, is like 1400 and the height of the patient is 1.6, then you can calculate, and then it gives you and you need the age of the patient as well, like 32, and it gives you based on this male classification, it can give you where your patient is located. So this patient with that parameter, with that high total kidney volume, with this age, is actually the class 1D, which considered as a high risk for rapidly progressive disease. And this patient with a normal GFR, you can consider for initiation of the general Q, the TOLVAPTAN. Okay, so let's go back. So any other questions you may have?
Ehsan, once you start a patient on a Vaptan and assuming they don't have any liver toxicity, how long do you just indefinitely keep them on it? And what is your threshold to take them off the agent? Beyond which, like once their GFR eventually declines, is there a point beyond which you just keep it just for symptom control, or is it the renal endpoint? Like, how do you decide when to stop the drug?
Basically, the data that we have from Tempo and Reprise, you can start up to patient with the GFR more than 25, and then you can continue, and then until they reach the
Dialysis or okay.
So, unless there is a liver toxicity or anything like that, then you can damage, but we will continue as long as they can tolerate the medicine.
Okay. Has it also been shown to be of any benefit in people with normal LFTs with polycystic liver disease?
So for the patient with polycystic, so what they have, I think when I look at their study and the label, so they're saying it has the effect. They assume that it has a similar impact on the cyst, and that's why in those patients with polycystic liver disease, you can still use the general Q. I would say due to the similar mechanism of action and the cyst formation in the liver.
Got it. The other final question I had was, there's the typical textbook criteria for screening for intracerebral aneurysms, including in high-risk situations, neurologic symptoms, anticipated major surgeries. All that is like already with the standard criteria. There was like some recent French analysis, I think a couple of years ago, that showed that it was actually cost-effective to universally screen every patient. Do you know if there's any guidance on that?
Low threshold. I agree. I do have a low threshold to screen them for aneurysm, especially if in the future, if they need to go for the kidney transplant, definitely needs to, even in asymptomatic patient, I have a low threshold to order imaging study to exclude that.
Cool.
Any other questions?
All right. Sounds like there aren't any other questions. Thank you so much, Ehsan. That was great.
Thank you.
If you don't mind, just send me your slides later. I'll put it on tomorrow.
Will do.
Thank you, Ehsan.
Take care. Bye.
Thank you.